Good afternoon, good evening, everybody. I'm Rohana Kapkatua. I'm Secretary General, Pathology and past Chairman, Fibo Menstrual Disorders Committee. Firstly, I would like to thank Dr. Rishikesh Pai, the Regional Director for the Asia Oceania region of FIGO, for giving me an opportunity to speak in this FIGO webinar on new advances in reproductive medicine. I also like to thank Emily Rice and others in the FIGO for the assistance given to. So my topic is advances in the patients with uterine pathology. So the uterine pathology can result from absolute uterine factor, that is infertility, or non-absolute uterine factor infertility. So the prevalence is not exactly known. It may affect 3 to 5% of the world population in UFI, and in AUFI 1 to 500. So there is when you consider the absolute uterine factor infertility, you have the congenital form, the uterine agents, MKR, MRK syndrome, and acquired where you have hysterectomy. In the MRK syndrome, there is congenital aplasia of uterus in the upper two-thirds and the vagina, and it affects 1 in 4,500 women, needs adoption, surrogacy, or uterine transplantation. But in UK, these studies have shown that most women prefer uterine transplantation over surrogacy adoption, despite being aware of the risk. When you consider the non-absolute uterine factor infertility, there can be congenital causes due to the defect in the development of fusion of the Mullerian ducts, or acquired due to thin endometrium clips, intrauterine adhesions, fibroids, and adenomyosis, and so on. So the prevalence of uterine malformations uh, is about 5.5% in the general population, and it increases with infertile women and those with miscarriages. So therefore, it suggests there is a connection between congenital abnormalities and infertility. So it can be due to unification defects, which are due to the total or partial absence of fusion of the Mullerian ducts, like didelphys uterus, biconjugate uterus, and conjugate uterus. And also there can be canalization defects resulting in septum or septum defects, like causing the septate and partial septate uterus. So commonest is the septate uterus, followed by arcuated by conjugate uteri. So the diagnosis is mainly by 3D vaginal ultrasound scan. So these are some of the pictures. And in the uterine septum, there is a few studies supporting the causal effect of uterine septum on infertility, as demonstrated by improvement once it is removed. And the uterine septum, so there are several observational studies have reported the association between uterine septum and the obstetric complications, including recurrent spontaneous abortions, preterm delivery, intrauterine retardation, and so on. So it is recommended to counsel the patient that the presence of septate uterus is associated with spontaneous abortion and obstetric complications. So then if we consider embryo implantation, so embryo implantation success depends on the degree of the embryo development and the endometrial receptivity. So endometrial receptivity is the ability of the endometrium to allow the embryo to contact, localize, and adhere to an implant at a specific time, referred to as the window of implantation. The window of implantation usually is around 20 to 24 days of a normal menstrual cycle, about 7 to 10 days after the LH peak. So endometrial thickness is also something which may affect the success of the ART cycles. The thin endometrium is encountered infrequently, about 2.4% of persistent reproductive cycles, and pregnancies sometimes have been reported with 4 to 5 millimeter, but endometrium, but it is apparent that all endometrium thickness less than 6 millimeters is associated with a poor outcome. And ultrasound scan by clinically defines thin endometrium as that less than 7 millimeters. However, the definition of a thin varies from 6 to 8 millimeters. So the prevalence of abnormal thin endometrium increases with age. It is 5% on the younger women under 40 years and rises up to 25% in older patients. So here you can see this big study which was done in 3 Canadian clinics and shows that there is when there is fresh embryo transfer, live birth rates increases significantly until endometrial thickness is 10 to 12 millimeters, but then endometrial thickness less than 6 millimeters was with associated with the reduction. And there the causes of thin endometrium may be inflammatory, iatrogenic, or idiopathic. And there are several modalities which have been used to improve the endometrial thickness, like extended estrogen support, intrauterine granulocyte colony, luteal phase support, and so on. And also there have been so many adjuvant treatment regimes like estrogen, low dose aspirin, Viagra, and vitamin E, and so on. When we consider endometrial polyps, the high incidence rate in women with unexplained infertility. However, polyps contribute to subfertility is not very well known, maybe mechanical interventions or through intrauterine inflammation. And also there have been studies done to find the relation between the location of the endometrial polyp and the pregnancy rate, and it has been found that the endometrial polyps commonly found in the posterior wall. However, the excision of polyps which were located on the uterotubal junction significantly improved the pregnancy rates. So, if we are going to remove the endometrial polyp, it should be hysteroscopy directed polypectomy using scissors, loop electrode, or electric probe modulator. When endometrial polyps 10 millimeters size are found, it can be left alone because it may regress after the next menstruation. Endometrial polyps over 15 millimeters are less likely to regress spontaneously. Next is intrauterine adhesions. These have been found in as many as 16% of women undergoing hysteroscopy before their first cycle. And they have in women who have had miscarriages, there is a higher incidence. So it is usually caused by the tissue damage, mostly during surgical procedures, as dialytic urethra, and after pregnancy, miscarriage, and fibroid removal, and so on. The main therapeutic procedure is the use to hysteroscopic transvaginal resection of and hormonal therapy. But hysteroscopic treatment of severe adhesions may cause long-term major obstacle complications such as placenta accreta, preterm delivery, and even uterine. So they have looked for better options and have been trying stem cell therapy also. So these are the sources of stem cells. And then when you consider adenomyosis, the epidemiology has completely changed it from a older population. Now it is increasingly diagnosed in younger women with infertility and those with pain, AUB, or both. In women undergoing assisted reproduction technology, the prevalence adenomyosis is around 20 to 25%. So imaging transvaginal sound is the first line of imaging technique, and it has a sensitivity of 65 to 81% and specificity 65 to 100%. And now the reporting has been standardized using the MUSA criteria, which is shown here, and MRI should be considered only as a second line. And the new reporting system adenomyosis includes description of the disease location, whether it is focal or diffuse, presence of interlesional cysts in myometrial layer, whether it is involved, and the disease extent, how much of the uterine volume is affected. And so there is several theories for the mechanism of infertility. And the women with adenomyosis have lower clinical pregnancy rates after IVF and embryo greater accumulation of adenomyosis features when there are more adenomyosis features on ultrasound scan, it is associated with the lower clinical pregnancy rate. And also, it has been found that adenomyosis has a detrimental effect on IVF clinical outcomes, and the pre-treatment with the use of long-term GnRH agonists or long protocol could be beneficial. So it has also been shown that FET, fresh embryo transfer following GnRH agonist pre-treatment tended to increase the pregnancy rate in patients with adenomyosis, but the higher pregnancy rates is reported in those undergoing frozen embryo transfer after GnRH pre-treatment. Then we consider leiomyomas, it around 5 to 10% of women presenting with infertility are found to have them, and it is now there is a classification according to the newer PIVO classification. The cause may be due to the cause of infertility may be due to the uterine cavity distortion, impaired endometrial and myometrial blood supply, increased uterine contractility, and so on. So it has been suggested that submucosal fibroids have a detrimental effect on the chances of fertility, and it will be a benefit of myomectomy of submucosal fibroids. And type 0 and 1 fibroids are removed hysteroscopically and administering gonadotropin releasing hormone treatment for 2-3 months when the fibroids is over 4 centimeters will help preventing a two-stage procedure. And sometimes single type 2 submucosal fibroid over less than 4 centimeters should be can be removed hysteroscopically. And for type 2 fibroids of over 4 centimeters, serious consideration must be taken to remove abdominally. And subserous fibroids is less likely to impact ART, so hence majority of the subserous fibroids are left alone during IVF cycle. And regarding the intramural fibroids, it is less straightforward, and non-cavity distorting intramural fibroids with the management is very not very clear. Women with larger fibroids and those with fibroids that distort the cavity should undergo myomectomy. Try to avoid surgery when the fibroids are less than 5 centimeters and not distorting the cavity. Upper surgery fibroids of 5 to 6 centimeters if the woman has had 1 or 2 failed IVF attempts. Using uterine artery embolization, lower pregnancy rates and higher miscarriage rates and more adverse pregnancy outcomes have been seen, and it is associated with loss of ovarian reserve, especially in older patients. Therefore, for women requesting fertility, seeking future pregnancies should not be generally offered uterine artery embolization. So these are certain facts regarding uterine pathology and fertility. Thank you very much for your patience. Thank you.